Thank you very much for the opportunity to present. Our topic of discussion today is predicting failure in spine surgery. This is a vexed question because it is intimately associated with the definition of success in itself. So how do we define success? Well, there are obvious parameters here that make it quite definite. When there's radiographic success with respect to the goals of the surgery, where the patients achieve their clinical outcomes, whether it be patient-reported outcomes or other measures, objective measures, and so on, and we'll touch on that. And there is confluence with patient satisfaction, then that definition of success is easy. That is obvious to all. Similarly, failure is obvious when there's poor resolution of symptoms, when the patient is dissatisfied with the treatment that's given for a variety of reasons, typically no match with expectations preoperatively, and obviously where there is some evidence of radiographic or mechanical failure, that then also is an easy definition for failure. The issue with failure, however, is that it's not just the lack of success, and this is where the nuance comes in. The nuance of failure involves this concept of non-success as well. In other words, failure can capture more than just the fact that one parameter did not meet criteria, such as MCID, patient satisfaction, and we'll touch on that briefly. So it's multidimensional. Obviously, it includes neurological, clinical, patient-reported outcome, satisfaction, radiographic stuff, but also there is the element of cost and value as well. And if whether for value or even parameters such as time spent in the OR, in the hospital, and so on, those reasonable criteria are not met, that is also contributing to the definition of failure or non-success. So we come to this concept known as minimal clinically important difference. And this is probably a concept that is known well to all of us. But just to recap, it essentially challenges us to think about the minimum amount of, or the smallest change in a patient-reported outcome measure that the patient perceives as being beneficial or meaningful following surgery. And to circle back, it reflects patient-reported outcomes. We can shift over time from the expectation before surgery to that of after, and that is known as the shift response. So in other words, it captures more than just a pure, absolute, dichotomous output of whether the patient had a good outcome or not. And really, the best aspect of it is that it provides us a threshold for numerical manipulation so that we can gauge definitively patient outcomes. And once we have this MCID, we're able to assess our different patient-reported outcomes by it, attribute a certain threshold level by which success is measured, and this is always a range, obviously, and then think about guidelines or recommendations. And we also do this by pathology as well. So when we look at degenerative disc disease, when we look at fusions, spondylolisthesis, repair, and so on, we, from the literature, also have defined minimum threshold values that we recognize as meeting criteria for success or benefit to the patient. So this then brings us to this interesting concept of, well, failure is not just all success being lost, but there is this concept of MCID being met for pain, for example, or disability, but not for others. Then where do we set this threshold for what failure is exactly? And this then comes to our definition of the model and how we choose to see the paradigm of treatment for the patient. Adding complexity to this also is this concept of patient satisfaction. So it may well be that your patient meets patient-reported outcomes with respect to pain or disability or quality of life, but if they are unsatisfied for a variety of reasons for the surgery, and it could be simple reasons such as patient communication interactions or so on, then that's impactful. So let's look at these very briefly. This concept of PASS, again, it's probably a concept known to us, but worth touching on, is an improvement on MCID because it provides us an absolute threshold. It is not a gap or a delta. It is an absolute threshold at which if a patient meets that threshold, they are satisfied. In other words, they internally have met a criteria which they define as success. And it's more about patient satisfaction than improvement. Then we have substantial clinical benefit, which is, was there major improvement for the patient or not? So if we turn these and we dichotomize spine surgery into cervical and lumbar, there's a few factors that come out from the literature. One is that for cervical, we found that previous surgery did not really impact whether the patient was satisfied or not, as long as they achieved their PAS or their internal satisfaction threshold. Satisfaction was highly correlated with pain relief as opposed to disability. When we come to lumbar, there's a plethora of data. And here are the factors of importance for us to consider. Baseline PROM severity, frailty index, mental health with respect to depression, catastrophizing, and so on, whether the patient underwent revision status, and the degree of opioid dependence. And there's also other factors too. Complications obviously burden patient satisfaction, again, because it drives a delta between expectation and reality. That's dissatisfaction. Communication quality independently predicts satisfaction. And all of this is linked also to reoperation rates that we discussed, and that drives value. Here's the problem with PROs, and if you take anything away, this is a little plug for the research that we've done. Patient-reported outcomes are immensely useful. They reflect patient vision of their outcome. However, they are problematic too. There is intense bias with respect to response, non-response, whether there is observer bias in terms of a patient observing their own benefit or not, as opposed to the physician. There is obviously an instrument ceiling and floor depending on the sensitivity of the questionnaire that's typically administered. And again, it always reflects the garbage in, garbage out problem. So again, as a plug to objective outcome measures, and we've discussed this at the meeting, at this meeting so far, there are definitive, well-known objective outcome measures that are entering our paradigm of thinking about spine outcomes. And these not only include gait evaluation, but all the way to REM for sleep, galvanic skin response for pain, cognitive testing, and so on and so on. This brings me back to finish up on the concept of machine learning and artificial intelligence, which is where all of this is heading to. A recent review looked at using machine learning to identify satisfaction and outcomes, and it found similar but slightly nuanced differences. And one was that the surgical approach is probably reflective of complications, but also it could even be to the point of discussion in communicating with the patients what the approach would be, together with the obvious preoperative patient-reported outcomes, but also mental health and cognitive evaluation significantly impact patient outcomes. And the future here is that we will have a dashboard of sorts which will be real-time, it will be dynamic, it will predict and alter the trajectory of patient-reported outcomes as time points pass. It'll be integrated with wearable technology or motion capture technology. In other words, it'll be some form of digital phenotyping. It'll be adaptive and it'll feed into our learning registries. And it's all about making personalized decisions with the patient. So in closing, I would like to kind of cast light on where I see the future of this. I think that obviously outcomes will always integrate the mechanical aspects. It will incorporate the psychosocial aspects and the biological aspects. We've used parameters that we now identify as being useful to record and follow and set thresholds for outcomes. But it also will feed into the things that we know we need to do, such as communication and counseling and so on. And the future will be patient-centered and predictive. Thank you very much.